Yeah, I mean, workforce, we're lucky that, in fact, as of 2 days ago, we will have no travelers, so no traveling surge techs or nurses, and there's nothing wrong with
Yeah.
that. But that's something that our board had said you need to take care of, and we did within 45 days or so. So that, from a workforce standpoint, OakLeaf has been known as a place, if you're a nurse or you're a tech or you're another position, pharmacy, that this is a really cool place to work. It's not the 24/7 kind of call type of area.
Yeah.
We have a really good lounge of food and everything every day, and it's small enough. What I love about this position is it reminds me of my critical access CEO days, where we had about 300 employees.
Hello, and welcome to the Shift Change podcast. I'm your host, Kelly Moore, and today I'm joined by Scott Polenz. He is the CEO of OakLeaf Surgical Hospital. Scott has a really broad healthcare leadership career. He's led a critical access hospital. He's helped build a new hospital. He has served in senior leadership at Marshfield Clinic Health System and has worked deeply in physician recruitment and alignment. So he's recently stepped in as the CEO at OakLeaf Surgical Hospital, and we're excited to have him here. Scott, welcome to the show.
Yeah, hi, excited to be here.
Great. All right, so let's get started with your path. You mentioned when we talked before that you had started kind of in the accounting field, and then you found your way into healthcare. How did that happen?
Yeah, I got lucky, to be very honest. I was a public accountant, like a CPA public accountant, and I was in a small town, and I was essentially, my clients were farmers, so I was counting cows. And one day, one day the owner comes in and says, hey, well, how do you think you're doing, Scott? And I said, I don't know. I'm not sure if this is my future, if I'm really good at it. And he said, well, I kind of agree. And then, and then, and then I had applied for a financial analyst job at Marshfield Clinic, and now Marshfield Clinic Health System. So I had no, vision or dream to work in healthcare, and could never have imagined being a little financial analyst. And what my career has evolved over time, it's been really cool. And I always say, difference between an accountant and a financial analyst is an accountant with a good sense of humor. So that's how that.
Love that. Awesome. So yeah, based on your experience, you've seen a lot of you've kind of sat in a lot of seats within the healthcare space, from consulting to physician recruitment, leadership, now CEO. Give listeners a kind of a view of your world today. What is OakLeaf Surgical Hospital? What kind of organization are you leading? And what are you responsible for kind of day to day?
Yeah, sure. Yeah. Well, my like you had mentioned it, I've done a ton of different things, and we'll probably dive into that a little bit
Mm-hmm.
now. But right now, what I found is that when I left Marshfield Clinic and senior leadership and physician engagement and recruitment, and went into consulting, I thought, this is going to be a great way to, a few more years, and then maybe retire and do some part-time work. And I just I don't want to say I got bored, but I missed a few things. I missed leadership, and being a leader. And at my stage of my career, I've had really good mentors, and so I want to be a mentor to other people. I miss patient care. Even walk around today, I was doing some walk around. I say hi to patients. I ask them if they need help or if they need a snack or a cup of coffee or something. And then the last one, I just really missed physician engagement, physician conversations, and I've always kind of fancied myself as somebody who really has deep relationships and experience with physicians, and I've learned, and maybe we'll get into that, but I've learned that physicians are just like all of us, and they want to be respected, they want to be listened to, and sometimes we make it much more complicated because people are kind of intimidated by, physicians are some of the smartest, most educated people there is, and how am I going to talk to them? And I have a great regard for physicians. In fact, rarely will I call a physician by their first name. Our board chair is Dr. Stewart. I'm not going to call him Nate, to his face. And even if they say, call me Nate, call me Sue, call me Bob, no, I'm going to call you Dr. Stewart because you deserve that. And I think you like it, and especially
Sure.
other people. So that was kind of a long. Oh, but yeah. So OakLeaf Surgical Hospital is a surgical hospital, and it's really in the market we're in Western Wisconsin. There are very strong systems. There's the Marshfield Health System, now owned by Sanford, that it's one of the largest rural healthcare systems across the country. And then you have Mayo in town. We used to have two hospitals run by HSHS out of Springfield, Illinois. And actually, sadly, those hospitals shut down about 2 years ago. And there's this very strong group of about 120 or so physicians that are, we call it the Oakleaf Medical Network, or essentially the independent physicians. And they would practice at these HSHS hospitals for their inpatient care and for their call for emergency department. And then they also partly owned with a national surgery company called Surgery Partners. They own a part of this surgical hospitals. It's a busy place, and we do about 14,000 surgeries every single year. And I was named the CEO. For now, I get to be in leadership, and all the things that I miss. I get to see patients, like I said, every day, and I'm constantly, communicating and talking to physicians and you know, et cetera. So I've been in this role for, I think it's 57 days. So it's
Yeah.
cool. And the other very unique thing for me, and what I think makes it really important, is and I told everybody in the interview process, whomever you hire for this job, hire somebody that's local. So hire somebody, because as we all know, healthcare is local, and hire somebody that's community. And for me, this is, I get to give back to the community that I grew up in and still live in, and it's very powerful.
Yeah, that's great. So you're 57 days in. When you step into a role like this and into an organization like this, what are some of the first things you're looking for?
Yeah, it's been the first is trust. And
Mhm.
it's been a difficult couple years for the organization, and I won't go into the reasons for that, but there's been a lot of growth and fast growth and communication challenges back to the day-to-day employees. So when I've came here, I've realized that building trust is number one priority. There's all these other areas that need to focus on taking care of patients, but at the end of the day, you can't take great care of patients and have high quality care and grow if you don't take care of your people. And the only way to do that and to build loyalty is to build trust first. So um, I'm a big believer in Frances Fry, who is pretty famous for, she talks at her trust triangle. And essentially she says, you have a triangle. So Kelly, let's say I reported to you, and she says there's three areas: being empathetic. So, you're there for me as a human being. Maybe I'm going through a tough time, and hey, Scott, why don't you take a day off? Or I know you're really, stressed out right now with that big project. How can I help? And then second is being authentic. So I know you, you know me, we know each other. We don't have to be friends, but I need to know that you're a real human being and that you have emotion and you care about me. And then the third is logic, like decision making. Do you communicate the why? So I've spent a lot of time, just like we talked about before we got on here. I walk in your shoes. So I was in the pharmacy department today, getting to know them and what they do and what their day is like. Because how can I lead the organization if I don't know what their day to day is? So
Mhm.
trust is number one. Number two is the physician growth and physician relationships, and then the third is really just trying to figure out, okay, so all of a sudden now our physicians who do their surgeries at our place or round on the patients at our place, now they don't have access to their patients on an inpatient stay, like a cancer care or a open heart surgery, things we don't do,
Mhm.
nor do they have access to their patients in the emergency department. So those patients might be going to a another organization and maybe getting, I don't want to say stolen is not the right word, but they may say, well, I'll do primary care at Mayo instead of the OakLeaf Medical Network or the independent network. So how do we figure out access points to be able to keep our patients within our system, which will ultimately help the network, the overall independent network, and then obviously the surgical hospital where, I work at.
Hmm. So you get in front of your people, which is critical to understand what's going on in the business, but you're also, reviewing reports and, other types of analytics to see what's actually going on in the business. How do you reconcile what you're seeing with your staff and with your physicians, with your pharmacists, and how that relates to what the data is telling you?
Yeah. Well, first of all, I'm a big I've been a big person with Quint Studer and now the Huron Group, and the Studer Group is a nationally known consulting really focusing on leadership development, and what we've implemented. And I was so happy because I was just in the pharmacy department, like we had mentioned, and the pharmacy director had on her whiteboard our pillars. So essentially, our pillars of excellence. So people, service, quality, growth, and finance. And so to me, you can't just put a report up about the bottom line of finances, which is really what we've kind of reported out in the past. You need to talk about your people and taking care of them, and that's where it always starts. And then they'll provide a high quality service and a safe service. They'll provide a great patient experience. You got to figure out how to grow, how to get those access points and recruit and retain your physicians and your staff, and then the finance will kind of take care of itself. So right off the bat, we need to put metrics together and have the data to support that, and then present that out. So I've already, talked to at the all staff meetings and said, here's how we're going to function, and here's how we're going to report out, and here's what's important to all of us. And oh, by the way, in your evaluation, in the future, we're gonna tie what our overall strategic plan is and our metrics of the organization to what you do on a daily basis, because we all impact everything. And sometimes as we don't get that down to the actual employees. So from a data perspective, I'm still trying to figure out, where does our data come from, and how manual is everything in an Excel spreadsheet, or
Hmm.
and if Luke, like for example, our CFO, if Luke is putting the spreadsheet together and Luke's gone for a month, or something happens to Luke, and so what do we do that? Kind of.
Yeah. Yeah,
So
and that's definitely something I wanna dig into, in just a little bit. I'm curious how what are some of the pressures that your workforce is feeling right now in terms of, urgency? Like, what kind of pressures are they under, and how does that bubble up to leadership in terms of, are you dealing with workforce limitations, or are you dealing with reimbursement issues, patient experience? What are some of the most critical or urgent pressures that you're facing?
yeah, I mean, workforce, we're lucky that, in fact, as of 2 days ago, we will have no travelers, so no traveling surge techs or nurses, and there's nothing wrong, with
Yeah.
that. But that's something that our board had said, Scott, you need to take care of, and we did within 45 days or so. Um, so from a workforce standpoint, Oakleaf has been known as a place, if you're a nurse or you're a tech or you're, another position, pharmacy, that this is a really cool place to work. It's not the 24/7 kind of call type of area.
Yeah.
We have a really good lounge of food and everything every day, and it's small enough. What I love about this position is it reminds me of my critical access CEO days where we had about 300 employees. I mean, I'll get to know everybody here and bring that kind of family like togetherness, and that's very powerful. So workforce, we're pretty good. We're a little stretched thin where we have some positions in the surgical areas that we're low on. So this, I think, the stress of the numbers sometimes is tough. The main challenge is the financial side and the access side.
Mm.
Where, if you think about it, if you're a general surgeon, um, you're going to get a lot of patients that are coming into the emergency department for a gallbladder surgery or an appendectomy, or something to that effect. and now we're not getting that. So that's really the biggest stressor is figuring out how do we get those access points? How do we grow, grow responsibly and be able to provide the patient experience that we provided. From a quality standpoint, we just had a joint commission survey, and it was the best joint commission survey I've ever been involved in. I think we had 8 citations, and majority of those are just because if they don't have any citations, that their bosses are going to go, well, what'd you do for those 3 days you're in Eau Claire, Wisconsin?
Yeah.
So quality patient experience were, above 90, 93, 94%, often. So it's really just about the restoring that trust, keeping the great employees that we have, bringing in other ones. We just hired a nurse from Mayo because she heard some good things about this place. That's exciting. Um, and then how do we grow, and how do we have those access points to be able to make sure that our surgeons are busy enough that they want to stay in this community and stay practicing at our hospital? Those are the big areas there.
Can
Um,
we go back to the part that you were talking about access, where if somebody has, one of these, urgent procedures that they need, like gallbladder or appendectomy, and they go to the bigger hospitals? Are you saying that, or are you saying that they go to the bigger hospitals, the bigger emergency rooms for that?
right,
And
right.
okay, so everything at Oakleaf, is it all non-critical or non-urgent?
For the most part, we do
Okay,
have some direct admits, direct admissions from smaller hospitals, but for the most part, they're scheduled, you know, spine surgery, scheduled orthopedic surgery,
okay,
scheduled general surgery, scheduled. Um, we will have some patients that may go into the doctor's office and say, "Hey, something's going on in my stomach," and they do an X-ray or scan and say, "Oh yeah, we got to take your gallbladder out," or something like to that effect. But for the most part, yeah. So when our docs are practicing at an ED, they're not getting all those patients, and then once those patients are going someplace else, they may say that organization, if they're running it effectively, may say, well, hey, Scott, do you have a primary care physician? Because if you do, we'd love for you to stay in our system. If you don't, we'll set you up on Tuesday with a primary care doc. And all of a sudden, our independent medicine group has lost patients, and we're seeing that now. Access points is very critical to us.
okay. I want to talk a little bit about how people outside of healthcare, um, what they may not understand about how to operate one of these organizations. So, if you think about, other industries that are reliant on, highly skilled workforce, managing schedules, managing patients, things like that. What is some of the most, maybe surprising aspects of operating an organization like Oakleaf?
Yeah. Well, that's a big, it's kind of big. It's very complex because if you think about, like, when I was in the larger systems and even doing consulting, I would go around and do speaking, and I would say, what I've seen in my past roles and what I've seen in consulting and other organizations is we're moving to an industry where we're treating our physicians like commodities. Um, and they're not commodities. They're certainly not commodities. And my body and your family's body are not commodities. These aren't witches. These are human beings that are all unique in everything that's going on. And everybody has, different needs. So the complexity of making sure that your physicians and your staff feel valued and have the equipment, pharmaceuticals, and everything to be able to do their job is it's very complex, and it's also
Hmm.
tough. It's 24/7.
Yeah.
You never know what's gonna come into the door, on a daily basis. And then I think what people sometimes don't talk about is I'll come back to, I want to talk about the insurance side, because that's where I think, if you're not in healthcare, because I've done
Yeah.
managing of my mother-in-law's, healthcare,
Hmm.
family's healthcare, and working with the insurance companies, it's out of this, it's incredible. But
Yeah.
is that when you think about the healthcare system, a lot of people say, well, you have a healthcare system. Well, we don't. We have all these different parts. You have pharmaceutical companies, you have medical supply companies, you have insurance companies, you have the government, you have doctors, you have hospitals, you have clinics. Um, and all of these parts of those are trying to make money, and they're trying to create value for whomever they're working for. But a lot of them are not in the day to day taking care of patients like the government
Right.
or like insurance companies. So it's very complex to try to bring all that together. And then you throw in the insurance side, where when you had mentioned before about challenges, we're seeing a different payer mix, meaning, you know, most healthcare organizations, if they're honest, will tell you they want to grow their commercial business, their insurance business, and their employer business as fast as they can. And, and that's, kind of, it's called cost shifting essentially, because you lose money on Medicaid, you maybe do okay on Medicare, but you have to make up for it and increase the cost of care on the commercial side to make up for the uncompensated or the Medicaid or the Medicare patients. So that gets very complex, and probably the number one area that frustrates employers and frustrates patients is the cost of healthcare,
Sure.
and rightfully so. But there's not one person. You can't just say, there's is the United States ever going to go to a Canadian type of healthcare system? I doubt it.
Uh,
There's not. You can't blame Scott. You can't blame. You can blame all these different people, but not everybody's coming together and trying to figure this out.
yeah.
It's honestly, one of our goals is to reach out to the self-insured employers and just say, look, we'll give you a great patient experience. We'll give you very high quality care, and we're going to do it at a lower cost. And we want to bring some certainty to that cost. So we're going to set an episode of care, or a bundle, for example. So if a hip replacement is, you know, $20,000 or $30,000, that's what you're going to pay for that hip replacement for your employer. And we won't have to go through the insurance companies and things like that. So that's where things get very complex, but also incredible opportunities.
Yeah, that is really interesting. I've, just kind of on a personal note, I've been looking at some of those, direct medical options that kind of take out the insurance company from the equation, and it's really interesting what options there are, but not a lot of people know about them yet.
Right, right, yeah,
Yeah.
and, like an MRI, for example. In this
Mm-hmm.
community, you can go to a couple different places and get an MRI for, 600,
Yeah.
$600, 700. The challenge is that the place where you're gonna get your surgery done, may not trust that
Yeah.
technology, or may say, "Well, you need to have one done at our place," and then you're like,
Mm-hmm.
"Got one done over here," and they're like, "Well, then you can't have your surgery here,"
Yeah.
so you're kinda at the mercy of this healthcare
Mm-hmm.
crazy.
Yeah, and for consumers and for patients, it's just really and for caregivers, it's just really, really complex and hard to navigate.
Right, right. And from a
Yeah.
physician standpoint, one of the things that I loved working for Marshfield Clinic was, and most organizations across the country, is it didn't matter, how our doctors were paid, whether they pay production or salary. It didn't matter whether the patient that walked in the door had no money or was, the richest person in the world. You were still you it didn't matter for your bottom line in your pocketbook what
Mhm.
that patient had. But on one hand, there's one argument that would say, well, if you lower your MRI, charge from $2,000 to $700 of cash, you're going to lose
Mhm.
out on, $1,300. Okay, well,
Yeah.
I can see what you're saying there, but did you know that X amount of people, the Kellys of the world, are going away from West. They're going to Costa Rica to get their hip done. They're going
Yeah.
to the Twin Cities to get their surgery done, or their MRI, or they're going to a different part of Wisconsin.
Yeah.
So you're losing all those patients. So that $700 or that $2,000 that you say we're getting, I'm not getting that because I'm not getting those patients because they're going someplace else.
Right. Yeah.
We're small enough, um, that we can make shifts in how we're going to get reimbursed for care. Excited to try to explore some of that.
Yeah. I want to move into technology. I want to talk a little bit about the different systems that are being leveraged and invested in healthcare. If we think about just kind of the broad industry of healthcare, EHRs, patient portals, scheduling tools, all the things. Um, what I keep hearing, or what I've heard from some of our healthcare clients and connections, is that kind of the day-to-day experience for staff still feels harder than it should, um, when it comes to the tools and systems and technology that they're using. How do you think of the reality inside healthcare operations as it pertains to the technology that's being leveraged?
Yeah, well, it's you got obviously you have your electronic health record. In fact, I just toured an ambulatory surgery center that doesn't have an electronic health record. They use paper charts and they love it.
Really?
Yeah, and when I was a critical access hospital CEO, I'm so old that we didn't we didn't have an electronic health record at that time. And I'll tell you that the docs didn't complain about the electronic health record. They didn't complain about being able to talk to you, Kelly, face to face as a patient without looking at their computer and typing things in,
Yeah.
and or going back and dictating and clicking 13 clicks to get one thing done. So sure, electronic health records have brought better safety measures and some efficiency if it's a good electronic health record. But for the most part, it's just made it more difficult for staff and especially for physicians. And then and I'm still, like we kind of talked about, I'm still learning all of our technology. We have Meditech as our EHR, but there's all these other systems and they don't necessarily talk to each other,
Yeah.
and that's where things get really really challenging. And when I walk around, I can see that there's still a lot of manual things that are
Hmm.
from a scheduling standpoint, from a staffing models, dashboard,
Hmm.
things like that, that I need to find technology and solutions to that make life easier and more visible so people know what their goals are for the day.
So, what are some of the workflows that you think could benefit the most from transitioning from manual to automated,
Yeah, well,
or
I think
being integrated into a system?
yeah, I think it's definitely scheduling,
Okay.
not a staff scheduling, but scheduling of patients. From my understanding, that still is, a scheduler on the phone saying, "Hey, I can get you in at 10:30. Oh no, wait, somebody just took the 10:30 slot. I got to cross your
Yeah.
name off and I'll put you down at 9:30." And write it down, and then so I think some of that is still quite manual. What I've been surprised by is there's not any visualization as to, in the OR, I keep asking, are we busy today? Are we not busy today? And what are our numbers? And so how do we take that data from wherever it's coming from, Meditech or some other system, and visualize it so everybody knows
Mm.
here's the flow. So I think there's some great opportunities there from an OR standpoint. uh,
Mhm.
the flow from room to room, staffing
Mhm.
models, like we had mentioned. So I just think there's a lot of technology, and we haven't even got into the whole AI
Mhm.
type of area too as well.
Yeah. Oh, yeah. Definitely have a section in our conversation for that. You mentioned, kind of the disconnected systems. What do you think are the consequences? What the consequences are of the disconnected systems when you are talking about, the different teams that need to know what each other are doing, and um, is it just annoying, or is it, real business risk?
Yeah, I think there's a lot of duplicative work
Okay.
that's happening. So people are not as efficient because they're double checking or they're
Yeah.
doing the same thing that maybe somebody else did in a different system. Or so I think there's that. I think there's some irritation to it. Efficiency, obviously, but I haven't seen that here. But I mean, clearly, if there's manual work or things going on, there could be patient safety risks at
Mhm.
harm. In fact, I spent a lot of time doing a little walk in your shoes in the pharmacy, saying, well, wait a minute, what if you typed in 1,500 milligrams instead of 150 milligrams?
Yeah.
And the system, does say, well, you can't, 1,500, would kill a horse. You
Yeah.
can't do that to the
Right.
patient. So the systems do have, some of those obviously area, but patient safety could be at risk if the systems aren't talking to each other, or if
Yeah.
things are manual. Then you think about, the whole billing side, and is that, are we still calling people on the phone, and
Mhm.
uh, is that all manual, or is that automated somehow? I think there are just, a million opportunities from kind of some of that more behind the scenes type of work that we call
Mhm.
the revenue cycle, essentially, when somebody walks the door and when you get paid, how does that all flow? I think in that area, we have a lot of different, I think we have quite a few different systems that don't talk to each other, that we need to evaluate and see, is there one out there that meets the needs of the whole organization?
Mhm. Do you think, going back to EHRs, do you think that they are more built for documentation and just compliance? Or do you think that they are also meant for operational, workflows? Like, how do you see an EHR being, really bringing the value, and also being able to solve some of the, um, you know, kind of the things that are missing from when it was just, paper records?
Yeah, yeah. Um, Yeah, I'm not sure I'm the best person to answer that, but in the billing side, coding and coding is a big part of
Mhm.
electronic health record. That's a really important part of this.
Mhm.
You're making sure that whatever's documented, so you can get paid appropriately. Now the
Mhm.
physician's like, so I got to spend an extra 3 minutes, documenting all these things and doing it right. So you, the hospital, can get paid.
Mhm.
Not a big motivator for the physicians per se. So
Are you leveraging the EHR for any reporting or analytics or anything like that, or is that through another means?
I'll find that out for sure coming,
Okay.
moving forward. So right now
Yeah.
I'm not 100% sure.
Okay. Interesting. And then almost last question on technology. I do want to get into AI and automation, but you had mentioned earlier the heavy reliance on spreadsheets. Was that with your finance team? Are they the ones who are really relying on spreadsheets?
Yes. Yeah.
Okay.
Yeah.
Okay.
Yeah. Yeah.
And is that just for like manual reconciliation and billing and things like that?
Reconciliation of financial reports and the analysis side, which really kind of does need to be, um,
Mhm.
does need to be in a spreadsheet type of area. But there are tools out there that I was pursuing as consulting that, are opportunities, even from a retention standpoint,
Mhm.
um, uh, uh, less than 25% of healthcare organizations have a formal retention program in place for physicians. And people will do this and do that, but there are systems out there, technology and systems out there to make sure you're doing all these different things to retain and stay connected with your physicians. That's an opportunity. Like for example, right now, I visited another one of our hospitals, and they do essentially an income statement or a profit and loss statement for every department, so for every manager. And I used to have that in my past career, and it was very powerful. You'd sit down and talk to, say, Kelly, you're overseeing the respiratory therapy department. Kelly, you're off by, $5,000 on your budget this month. What's going on? And you would just say, well, we had training for the electronic health record, so we had all these extra hours, and otherwise we'll be fine next month. Don't worry about it, Scott. Okay, that's great. Thank you. Um, right now at the place we're at, we don't have profit and loss statements for each of our managers or leaders of our departments. So how are they going to know, how they're doing from a bottom line standpoint and contributing, and where are their opportunities to, improve the financials of their department and the organization? Right now, I think that would all be manual, and there are systems out there that can do this for you.
Yeah.
Mhm.
Yeah. I want to talk a little bit about that part of your career that focused on um, physician retention, recruitment, alignment, all of those things. What do you think healthcare organizations might misunderstand about physician recruitment and retainment?
Yeah, I think everybody focuses so much on the recruitment side.
Hmm.
And oftentimes because of because I mean, if you think about the healthcare world right now, you have all these older, I'm not that old, but you have all these older people, and a 70-year-old is going to spend 7 more times than you're going to spend on your healthcare. So all of a sudden you got all these older people that are getting older, and then you've got a shortage. I believe latest number in 2033 is a shortage of 86 thousand physicians across the country, and especially in rural areas, it's going to be even worse. So all of a sudden you've got people that are going to need more healthcare, and you've got less doctors, and you have these financial pressures already. Um, so it's that's going to be something that is really important to not only recruit but retain your physicians and be flexible. What I find in a lot of larger organizations is once a doc turns a certain age and the doc goes, "Hey, I'm 60, kind of want to not be on call every third weekend and
Yeah.
work 2 days a week," or the younger physicians, female and male, that are coming out today, they're saying, "Scott, I'll come work for you, but I want to get paid what these guys are getting paid, but I'm only going to work 3 days a week. Take it or leave it, because somebody's going to pay them that." So there's flexibility at the beginning of career and flexibility at the end of the career. But what we do is we do a good job of recruiting for the most part, and then we onboard them pretty well, and then we forget about them. I'll never forget a physician. He'd been there 3 years, and I had recruited him, done all these special things for him and his family. And then he goes, "Hey, Scott, haven't seen you in 2.5 years. You forgot about me." And I was just like, I gotta find a career where that's never going to happen again.
Yeah.
So having those conversations, every 6 months, saying, "Hey, doc, how you doing? Well, how can we help you? How's your family doing? How can we integrate your spouse or your partner and your kids into the community? And how's the high school doing? Can we help you sell your house, or buy a house? Um, do you have a spousal program? Because if you don't have a happy spouse or partner, eventually the doc's not going to be there. Uh,
Yeah.
do you, as a physician, want to get into the leadership? How can we help develop you into leadership?" And so having those kind of conversations throughout their career and milestones, I'm big into. After 5 years, you get a couple more days of vacation, or a bonus or a sabbatical or something.
Hmm.
So many more things we can do to put a formal retention program in place for our physicians, that a lot of organizations are intimidated by that, or they just are getting through the day. The other thing that we recommend is that you have a 3 or 5 year recruitment plan in place. So that of your general surgery group, let's say you have 6 general surgeons and 3 of them are 67. Physicians are like NFL quarterbacks, are notorious for saying, "Hey, I'm going to work until I drop dead." Well,
Yeah.
we're going to plan. We got to figure out how to plan together. So have a formal
Yeah.
retention program or recruitment plan in place.
What are some examples of ways that you could fix the retention gap with, staying for leadership to kind of stay engaged with, the physicians?
Yeah. Well, so in my past role, I oversaw the engagement journey, and we did a press scanning engagement survey with our staff and our docs, and the scores were not that good. And my dyad partner and myself, we finally looked at each other and we go, "You know what? I don't know how we're not going to be able to improve this engagement until our physicians are aligned and have alignment." And what we meant by that was, our physicians, with COVID, a lot, sometimes executive teams, kind of, decided to work remotely, and then they never really fully came back and
Mhm.
spent more time in their office, doing Zoom calls or doing meetings and board meetings than they do in interacting and talking. And what we found is that if our physicians aren't aligned with the mission and the vision and the values of the organization, and just as important, or even more important, they don't feel that executive leadership is aligned in the mission, vision, and value, you're not going to have the engagement and ultimately the retention that you need. So you need to get out of your office. You need to round. I used to kind of joke when I'd round with some of our executive teams. I'd have a little fake little hat, and I would say, put your phone in my hat, because when we round, I need you to be focused, shaking hands, eye, having eye contact, and not looking at your phone or saying, "Hey, I got to go take this call," because you've actually done more damage by physically rounding and not emotionally being there. And like we talked about at the beginning, it's not as complex as we make it seem. Doctors know that. What I tell doctors, in fact, we had a physician strategy meeting the other day, and I said, "This is a dream job for me, and I just want every physician in this room to know when you shake my hand or I shake your hand, that means something." And yeah, there's a contract and there's stuff in writing, but it means that I'm going to have your back, and hopefully vice versa. And when we say we're going to do something, we're going to do something. But if we can't do it, I'm going to come back and tell you, here's why. Here, doc, here's what we can't do. Or, here are the three things. Because a lot of times physicians will say, yeah, the CEO rounded and I told her three things that I needed and I didn't get any of those three and I didn't even get a conversation. And the doc, they're big boys and girls. If you said, thanks, Kelly, thanks for Dr. Kelly, thanks for those three comments. We can do one in next year's budget. 2 and 3, we aren't going to be able to do it because of X, Y, and Z, but here are some other solutions. You're going to go, okay, thank you. I appreciate you listening
Right.
and getting back to
You
me.
just don't want to be ignored.
You don't want to be ignored. Yeah.
Yeah.
Like anybody in life. So,
Yeah. Where are teams doing heroic work right now just to keep the operation moving? Where are things like where you depend on them and they come through?
yeah, well, obviously the nurses and the surgeons and things, and even in the pharmacy area, we were mixing up a chemo drug. And the steps that the pharmacists and the tech had to go through, they had to wipe everything down in the middle area and then take it into the negative pressure room and wipe it down again and then clean the hood and everything. And I was just watching it, I was just go, oh my gosh, if you don't wipe that stuff down and you just become, kind of lazy and, well,
Yeah.
what's the big deal? Somebody could get an infection, or somebody's life could be impacted. And the thing about local healthcare is that could be your neighbor, that could be your mom, that could be your dad.
Mm-hmm.
And so to me, those type of things are kind of the day-to-day hero. The things that sometimes are more powerful for me, though, are that person in the dietary department or that EVS person who's cleaning a room, who can make something
Yeah.
day by going into the room and just saying, "Hey, Mrs. Smith, how was your, how you doing? How's your surgery? Is there anything I can get you?" It looks like you drank your apple juice. I can ask the nurse if you want another one, or tell me about your kids or your grandkids. And one of the best stories I ever had was I was walking to a meeting, and supposedly I was really busy and I was in a hurry, and I stopped this couple, and they looked like they're confused because at the place I was at, we closed one cafeteria, and they were trying to find the other cafeteria in the hospital. And I said, "Well, I'll walk with you." And her husband goes, "She just had her trach taken out and she hasn't eaten for months." And I go, "Oh my gosh, what do you want?"
Wow.
And she goes, "I want an omelet with ham, cheese, and tomatoes." I go, "You are going to get the best omelet you've ever had." So I walked back to the kitchen, and I said, "I want you to make the big deal out of this. Um, Make this great omelet. Come out there with a piece of cake and a candle, and make a big deal out of it." And they did. And then I saw them in the hallway, um, back, and they were just tickled. And I guarantee you,
Love that.
from a business standpoint, they were from a small town. They're going to tell everybody in that small town you
Absolutely.
guys did for me. And this guy with a suit who looked like he was hurried and busy stopped by. I don't remember his name, and et cetera. And then that kitchen staff. So to me, the kitchen staff that took my little, ask and went above and
It
beyond,
came through. Yeah.
they're heroes. So
Yeah. That's amazing.
yeah,
That's
because when you
amazing.
think about if you think about people coming into healthcare, coming into a
Mm-hmm.
clinic or coming into a hospital, for the most part, they're not walking in, going, "I'm so excited to get my hip done. I'm so excited to get chemo
Exactly.
today." So they're
Yeah.
nervous as it is, and we all,
Mm-hmm.
the smallest things in life can make their visit, um, less stressful.
Yeah, for sure. Okay, before we wrap up, I do want to talk a little bit about AI. I'm really curious about your position on AI and automation in healthcare, in the conversation in healthcare right now. Where you think the opportunity is real, where, there's just a lot of hype, getting ahead of reality. Um, what parts of healthcare do you think are most ready for AI or automation? And where would you say, we just need to still be a little cautious about things?
Yeah, well, that's a great question. We don't have Our organization does not have an AI, strategy at all. From OakLeaf or from Surgery Partner standpoint, we don't have a strategy, and we need to. So I've actually assigned somebody on our team to kind of be that go-to. So when I took this new job on LinkedIn, and I'm not on there that much, but I was on there a little bit for consulting. I probably got 400 messages from salespeople that acted like they were my best friend, and I'd say 90% of them were AI things, and and some of them wrote notes, and I don't even know what you're talking
Yeah.
about.
Yeah.
So if you think I'm going to spend 20 minutes of my time to talk to you about something that you wrote to me that I don't even know what the initials stand for, you wasted my time and your time. But
Yeah.
so I do think there are a lot of opportunities. I think there, I don't want to speak from a clinical standpoint,
Hmm.
but from a non-clinical and kind of behind the scenes, the, the AI from, like we've kind of talked about, from the OR flow, from the scheduling
Hmm.
models, how we communicate, I think is really, really important. I use when I'm going to get in front of the staff and talk about things, I'll, say, here are my
Of
thoughts,
course.
flesh this out for me
Hmm.
or make it stronger or whatever. So I think from a communication standpoint, we can use AI, a lot more, from how we're presenting our metrics, so think the scheduling and the revenue cycle. If I had to say, if you said to me, Scott, what's your goal? And then that, for 2027, it would be evaluating AI on the revenue cycle. I think there are opportunities, and I'm not smart enough or educated enough to know what those are right now. But that's a top priority, is probably rev cycle and just kind of the scheduling side.
Yeah, I mean, that makes total sense. I think you're on the right path. It's, the administrative burden. That's kind of a low-hanging fruit when it comes to AI integration. It's figuring out which operational workflows or, administrative tasks that you can automate to free up your staff for more, complex work. It's kind of taking some of the low-level tasks and automating all of that. So I think, you don't have to just go all in. You can start very small and, like you said, kind of build out a strategy. And looking ahead, 3 to 5 years, what do you think healthcare leaders are going to need to be much better at, with kind of the change in technology and, AI enablement and things like that? And if you're thinking non-technical as well, like what are some things that you yourself are kind of focusing on? Um, and where you think healthcare leadership in general should be focused.
Yeah, I think. Well, I'll start with the non-technology side. I
Mhm.
say building trust and having presence and recruiting the right people and retaining them, engaging them, and then retaining them. I think that is mission critical, and oftentimes it's just kind of a given. Like, we have an engagement survey coming out, um, coming out this week or so, and I'd love to have 100%. As long as they're not on FMLA,
Yeah.
I think it speaks a lot to, are people willing to fill out the survey? They fill it out because they love the place, or they fill it out because they, have some complaints or some questions,
Mhm.
or they fill it out because they know somebody's going to do something with it.
Yeah.
So just the whole engagement, retainment, if you think about it, I work way too much, but most people are working at least 40 hours a week. And so we're spending more time with our coworkers, than we do sometimes
Absolutely.
with families. And
Yeah.
in fact, this morning I said, a lot of people want to define culture and engagement. And I simplify it just saying, it's, what do I feel like on Sunday night or Monday morning? When I'm getting ready to go to work, am I excited, or am I like dreading to go to work? Because I've
Yeah.
had both. So that's a big part of it. I think, from more of a technology standpoint, is how do you bring all these systems together and have them speaking as one? Uh, like I'm in the pharmacy area. Well, okay, what is this part of? What is this part of our EHR? Is this a separate system? Same conversations for revenue cycle, et cetera. So, how do you bring all those systems together to work, to work for you? I think is a huge opportunity. For us, it's the access to patients, and then the last one, or another important one that we've talked about already, would be the affordability of healthcare. I truly believe that. Um, if you as an organization don't figure out a way to meet the needs of what the employers are asking for, they're going to go elsewhere. So how do we bridge that gap of margin and growth and meeting the needs of our employers?
All right, before I let you go, we're going to do a quick lightning round. So I'm going to ask you a few questions and you can answer with the first thing that comes to mind.
Hmm.
Ready?
Hmm.
Okay. Most underrated role in a healthcare organization.
EVS,
Okay.
environmental services.
Healthcare
Oh,
technology to
oh,
oh,
sorry. And the people at the answering the phones, the front desk, the
ooh,
people that are welcoming the patients.
good one.
They're
Good one.
so important. And from an AI, I would say, back to your AI question, people that are going to call this place are never going to call and have the automation go right off the bat. It's just,
Yeah.
my mom and dad would just roll over in their graves if we did
Oh,
that.
yeah. We've talked, not to get too off topic, but almost every leader that I talk to who works in healthcare or hospitality, the demographics, the range is so huge that, somebody, Gen Z or, millennials have no problem with that. But when you get into 60, 70-year-olds, they are not going to be okay with that. So, yeah, I'm hearing that a lot from people that I talk with about automated voice, answering phones and things like that. Okay. Healthcare technology today, helping, hurting, or both?
Both.
Okay. One healthcare process that should have been fixed years ago.
These are tough. I'd say billing, insurance,
Okay.
revenue cycle.
Yeah, that's a good one. AI in healthcare operations, game changer or overhype?
I think it's overhyped.
Okay.
I'm not strong on that, but I think it's a little overhyped.
Okay. And then last question, what would you be doing if you had not gone into healthcare?
Oh, I'd be a high school boys basketball coach, big time.
Ah, I love that.
Yeah,
That's fantastic.
yeah, yeah.
All right. Well, Scott, this has been a great conversation. I really appreciate your perspective and you giving me your time so generously. So, if people want to find you, follow your work, or learn more about Oakleaf Surgical, where should they go?
I think I'm on LinkedIn. I don't know what my address thing is or anything like that, but
They can find you with your name, I'm sure.
yeah, and LinkedIn there, but well, here's what I would challenge people that are on LinkedIn. And as a fact, I was talking to somebody about this, because I got, like I said, I got 400 messages, and there were a couple that one gentleman wrote me, and I wrote him back, and I said, I have no idea what you're trying to sell, but I loved your message to me because you respected the fact that I'm new, and I'm not going to drop everything to meet with you about something. And
Hmm.
so when you're putting these LinkedIn messages, when you just do this automated, they friend you or like one of your, posts that, and then they send you an automated note, and then they send you another automated note, another
Yeah.
automated note. Um,
Yeah,
so from my advice to people is make it you, just like when we were recruiting docs. I would always say to our recruiters, do something unique for that physician and their family. Um, and I could tell stories, but we don't have time to do that. But if you make something unique that's specific to that person, that will have an impact on them. So yeah, LinkedIn, or I don't think I should give out my email address here, but I think people can figure that out, or you can do that if you want.
sure. All right. Well, thanks again, Scott. And thank you to everyone listening to the Shift Change podcast. We'll see you next time.